Hello, everybody. My name's Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. Tonight, we have a very timely and exciting topic and panel. We're going to be talking about dual mobility hips, their wide range of uses, or as like to say, its time has come to really talk about them. I have two panelists. I'll introduce them one at a time. They'll tell you where they're from. They need no introduction, in my opinion, but we'll start with Michael Baratz. Mike?
Yeah, good evening, everyone. Thanks for having me on. It's Michael Baratz. Actually, almost everybody says it wrong, and I think maybe I'm the one saying it wrong. Sometimes it's so common. But anyway, I'm in Boston, Massachusetts now. I'm in a private practice, but I work in an academic setting a lot. I'm primarily out of the Beth Israel New England Baptist network here. I'm originally from Massachusetts. I went to Northwestern University, then Jefferson Medical College, Harvard Orthopaedic residency, Ortho Carolina for fellowship, and I specialize in total hip, total knee. I do quite a few revisions, and I do quite a few dual mobility, and I'm excited to talk about the topic tonight.
Excellent. And I'll have Bill Hozack introduce himself.
Yeah, hello everybody. I hope you enjoy the next hour. I'm in Philadelphia. I've been a member of the Rothman Orthopedic Group since I started practice quite a while ago. I won't say when. And a professor of orthopedics and joint replacement at Jefferson University. I specialize only in hip and knee replacement. That's what I've been doing since I got into practice. Just as a disclaimer, I am a consultant for Stryker, so there are some potential conflicts of interest as I talk about what I do in this area.
All
I
right.
should add that as well. I'm also a consultant for Stryker, as a full disclosure.
Well, I will give my disclosure. I was a former fellow of Bill Hozack's. Um, the first year he was in practice at the Rothman Institute, and that was not last year. Okay, so we'll leave it at that. Okay.
Yeah.
Why don't you start us off? Why don't you tell us what you feel about the concept of dual mobility cups in general? There was a time when I remember when I was a fellow, we did quite a lot of revisions and we didn't have dual mobility cups. You know, I kind of remember my mentor, Bill Hozack, doing a pretty fine job without needing them. But what's happening? What's going on? And and what explains the pervasiveness of this great new technology?
Yeah, I mean, I think that one of the biggest reasons for revision, a patient getting after total hip, getting a revision is dislocation. Instability is still an issue out there. We've gotten better at it with different technologies, whether it be using fluoroscopy or robotic techniques. We still have instability as an issue to address, and I think dual mobility gives you larger effective head size, larger bearings, and I think that is should mitigate some of those risks of instability. So you get a larger effective head size, and there is something about the actual dual articulation that also helps with range of motion tool impingement. So, I think it exists to address, one of the biggest topics still in hip replacement is how do we deal with instability?
And Bill, what are your comments about the idea of the use in primaries? Is there a role and who would get a dual mobility in a primary? Because Michael talked about the revisions.
Again, I agree that the biggest role is in the revision surgery, and dual mobility is not a new subject. It's been around for a long time. It was first developed in France quite some time ago, and over 40 years ago, actually. And I mean, I use it also in primary hip replacement. The indications are, somewhat variable. The ones that I tend to use it for specifically are those that one might consider being at higher risk of dislocation. For example, patients with hip fractures. That might be one category. Another category is people that are cognitively not quite there or have some neuromuscular disease that potentially puts them at higher risk. The newer one that people more more commonly recognized now is those people with specific types of spinal stiffness or spine fusions or stiffness of the spine, which creates a situation where the hip is potentially more unstable. And, I have some other indications, and we can certainly talk about it in more detail, which is those patients that are very mobile, hypermobile almost, but mobile. And they tend to be women who are relatively small with small head sizes. And for me, it's not only just a dislocation risk, but it's also a risk of impingement with range of motion. And in those patients, I sometimes, or many times, use a dual mobility bearing.
That's excellent. Mike, your feelings about that? And by the way, if anybody has any comments, please put them in the chat. All right. And we'll call on you, and you'll undo your video and you'll add questions in the chat room, please. That'll
Yeah.
be good. So
I agree with Bill. I mean, the thing is, and just to clarify, I think that in the revision setting, dislocation risk is even a bigger concern because there's soft tissue loss, abductor deficiencies. There's all these different reasons why a revision might have a higher dislocation, but we still have a risk of dislocation after primary total hip, and certainly approach might matter and other factors. But to Bill's point, I have some patients who are a little older. I have an 80-year-old patient she still teaches ballet. She's hypermobile. She's skinny. She wants to do all these things. And, I think she probably has a stiff spine as well, given that she's 80. So, I think it's an excellent choice to do mobility, to get a larger ball, to have a larger range of motion for impingement. And so she can go back to doing the things she wants to do. So I don't use dual mobility really frequently on primary hips. It's probably less than 10%. But there are plenty of indications where I think it's necessary.
I'm going to just comment. I'd like to comment, Ira, I want to make sure that, we talk about revisions and have dislocation risk, but if you look at primary hip replacement, the causes or reasons for revision, dislocation is in the top 3. So it's not like an uncommon problem based on registry data.
right. And I think that brings up a good point. I know both of you have used the Stryker modular dual mobility, but there also are monoblock cups. Can someone comment on that?
Yeah, I mean, Mike, I don't know if you have any experience, but I have access to the monoblock cup from Stryker, the Nove Dual Mobility, and yeah, it works well. I mean, I use this specifically in patients with small bones because even with if you have a 48 millimeter cup, I struggle some, depending on the cup, you might struggle getting a good bigger head size in, and the monoblock cup offers a head size that's only 7 millimeters smaller than the actual cup size. So it goes down to 41 millimeters in size. So you can get a big head size in a very small patient.
It gives you a lot of range and options.
Yeah.
Mike, have you used that at all yet?
Yeah, same. Actually, I've just recently had access to it. Actually, I did have access to it a few years ago. It's a French company, and it was initially being serviced by one manufacturer in this country, and it's now been purchased by Stryker. So I've had access to it. I think Bill hit the nail on the head. It really is about the smaller patients, so where you can get a large effective head size at a relatively small socket size. So and the reason is you're not using up the space with the modularity. You have a shell and then a liner. It's one piece. And it has an impressive press fit to it as well. It's a stainless steel with hydroxyapatite coating on the backside. It has normalizations and a little bit of a rim fit. It has an excellent press fit, even in some of the elderly patients with hip fractures.
You have any age limitations on dual mobility in any sense, Michael?
No, I mean, I think that well, in the younger patients, I don't really feel totally.
I meant more on the younger patients.
Okay,
my apologies. My apologies.
So I think a young patient, I'm extremely unlikely to use it. And I say young, I still think, probably under 65 is very young, and even under 70. I'm not using it very often, but in a very young patient, I'm not using it. So I don't know if I have a hard cutoff, but in the younger patients who are, I think less likely to have a dislocation, they have more mobile spines. more on average. And I think they have probably better muscle strength and control. I'm unlikely to use a dual mobility on them.
Bill, your agreement or not? What do you feel?
Yeah, I basically agree with Mike. I think the issue for the younger patient is not so much, well, dislocation is still an issue, but they tend to have better soft tissues. And I think that using a prosthesis such as a dual mobility, which is primarily to address dislocation, is really not necessary. Again, with the proviso that, yes, if I have a small patient with small bones, I would defer to a monoblock dual mobility count.
John Minter, you have a question. John, you want to unmute yourself and maybe and show us your video, John? You there? Otherwise,
Well,
I'll
I definitely don't have a video, but the question, comes up with proximal femoral replacement in these limb salvage cases in which honestly there's just nothing there. And a lot of times you just have to leave it to chance. You do the best you can. But I was just curious, what everybody would say about this, because I tend to maybe try to figure out a way to add more offset as well as more limb length. Those patients are probably going to end up with a shoe lift on the opposite side, just in an effort to put more tension across that joint with the dual mobility, versus just going straight to a constrained liner. Thoughts?
Yeah, I mean, I first of all, I don't do a lot of proximal femoral replacements. I mean, and that's a real salvage operation. Obviously, that may be done for multiple revisions, severe bone loss, tumors. I think whatever you can do to keep that hip in the socket, is probably the best. I think if you have a large bearing, I think a dual mobility makes sense. If you really have no soft tissue, abductors are gone, even at the best dual mobility is probably going to have some instability issues. So maybe a constrained liner makes the most sense there. Maybe you start with a dual mobility, and if that fails, you go to a constrained liner after you get ingrowth of your cup. But that's a tough problem.
Yeah.
Yeah, I'll pipe in a little bit. I mean, I've had some experience with proximal femoral replacement over the years, but again, not a high volume. And it's only been for joint replacement issues, not tumors. So it's usually a failed joint replacement or residuals of infection or something like that. And I didn't really originally have any access to either dual mobility or constrained components. And so it was always a bit of a challenge. But for example, in reimplantations for infection, we used to do 2 stages, leaving the limb short for a while. And, I think both are good options to have either a dual mobility and or a constrained component. I didn't really have any problems with constrained cups. These patients were not very active in general. The soft tissues were horrible and they tended to loosen up with time. So yeah, both can be used. I think you're still at, with the dual mobility, there is that potential that it could dislocate, but I think I would defer to that if it's possible.
Yeah, for a while there, when we had more of an abundance of 40 liners, I would do a 40 bipolar inside those in an effort to because that was really that's really kind of all we had. It was almost like predating dual mobility.
Yeah, I've done that too. You remember I've done a few of those too. Yeah.
Yeah. That's some back in the day stuff, right? Okay, just curious. Thank you. Thanks for the question.
Yeah. Thank you, John.
Yeah.
Really good. And if people don't know, John runs Health Run Disastroplasty Conference. Just a shameless plug right there.
Thank you.
For disastroplasty.org, a registered trademark of disastroplasty.org. Russ Bodner. Russ, you have a question there, Russ. Could you unmute or will I ask you a question? You got it. Good.
Yeah. My question has to do with placing dual mobility cups. We talk about the indications, but we don't really talk specifically of how you put them in. You just use anatomic landmarks, sort of like the way we've always done it, or because these are high-risk patients, do you calculate in any way an individual position for them? Do you're planning any different in revisions than in primaries? Or do you think it matters with the jump distance that you can put them in almost anywhere, and as long as they don't come out, you've got to win?
Yeah, who wants to take that
Why
on?
don't you go ahead? Oh, go ahead. Sorry, Ari.
No, I was going to say, who wants to take that on? Yeah.
Go ahead, Bill.
I think there's probably a couple of different ways to answer that question. I mean, I think, when I talk about dual mobility, I say, well, it's a great option for instability, but you can't just use that as the only solution. There's more to it, right? The component position is very, very critical. So if you put a component in the wrong position, i.e. retroverted or something like that, really the advantages of dual mobility are lost. You need to restore offset and leg length so the soft tissues are adequately tensioned. And you need to test for impingement at the time of surgery because, there are complications associated with dual mobility bearings. And so you need to maximize the soft tissue environment around the hip, even though you're using dual mobility. So you can't ignore those issues. How I put the cup in, I tend to use anatomic landmarks. There are other ways to do it these days robotically that may be better, but I don't know that there's an exact right answer on that one.
Yeah, I mean, I think that whether you use dual mobility or a traditional bearing, I think the same rules still apply for cup position. I mean, I think that the dual mobility and the larger bearing, it gives you maybe a bigger window, or it mitigates those risks of dislocation. But in reality, you still have to really pay attention to whatever it is you use, whether it's robotics or fluoroscopy. And I use a combination of things. That when I'm doing cases, I'm looking at bony landmarks, but I'm also getting on an anterior hip. I do fluoroscopy and I try to reproduce their standing pelvis. I think there's been a lot of stuff at AOS and ACUS over the past few years about the whole spine pelvis stuff, which is very valuable and fascinating and a little bit hard to understand, I think, for anybody. But the principles apply if you see a patient with like a really rigid pelvis and they have a flat back, for example, and their pelvis is tilted forward. I think they may be at risk for anterior dislocation. So I might sort of defer towards a little less anteversion on those patients. Or if they're stuck in the sort of standing hyperlordosis, they're probably more likely to dislocate out the back. So I might add more anteversion. But in general, I think using the dual mobility doesn't take away those rules. It just gives you a bigger buffer.
Yeah, that was the point of my question. And that you get a false sense of security when you use a dual mobility, thinking, well, I've got this big head, it probably won't come out. That component position isn't quite as important, but it actually may be more important because they're high-risk patients, and in revisions, they have high risk of instability. So everything you can do to plan properly, which includes both the component position as well as the coronal leg length offset issues, are very important.
I will add one last thing. So, I think that all else being equal, if you have identical position of implants, femoral and acetabular side, identical length and offset, a large dual mobility compared to like a 32 or a 36 ceramic is going to have a lower risk of dislocation. But if it dislocates, it can be a disaster. So that's one thing. And maybe we'll get to this later, Ira. But if a dual mobility dislocates, close reducing those has some serious problems. And I've had it happen to me. I've seen it happen in other places where intraprosthetic dislocations, the soft tissues get buttonholed, and you think you've got the hip reduced, but you've got the small ball in the cup and the big ball in the abductors. And so if you guess wrong with dual mobility, it can be a really bad problem.
I agree. You got to be. I agree. The general feeling for me, my feeling is that cup position, soft tissue stability is critical no matter what type of component you use.
No, it makes sense. I mean, it always begs a question. Some people who have a high dislocation rate seem to feel that dual mobility cups are sort of can make up for poor technique, and I guess we have a uniform agreement on that does not, it's not a fix-all.
Yeah, a uniform agreement to disagree with that statement. Yes.
Yes, yes, the uniformly you disagree. Yes, yes. No, it's good. Is there any reason not to use a dual mobility on every case you do. Okay, let's say people over 65. Okay, I will take that away, Michael, because
I mean, I think
I've had some discussions with some attendings at my institution, and there's one that is has like 5 times the dual mobility rate as the other person, and I'm trying to figure that out.
Yeah, I mean, I think the number one thing that jumps out when I think of that question is cost. Like, we're trying to reduce healthcare costs a little bit, right? And so, if you're looking at doing it on every single patient and you don't have a really clear indication of who needs them or does not, it's just a cost burden probably to your hospital, to your surgical center, or to healthcare in general. Um, that being said, an ounce of prevention can prevent a pound of loss, or whatever the actual expression is. But if you really think someone's at really high risk for dislocation, then spending that extra $500 or $1,000 or whatever it is, the agreement is totally worth it. You're saving the patient a revision, maybe. So but I think it's our job as surgeons, in the field, I think, to try to identify those patients so we're not spending it on everybody.
Yeah, I would comment the same way. I mean, I was using dual mobility at an ASC, and not frequently, but reasonably occasionally, and nobody else was. And I was identified as being a high cost surgeon. And I think so. The cost is probably the biggest reason not to be using it in every case. If my suspicion, if the surgeon is doing a good technical job, either DA or posterior, and pays attention to component position and soft tissue stability, the dislocation rate is going to be pretty low, right? So it doesn't make sense on a person with a less than 1% dislocation rate to be using 100% dual mobility. It just doesn't make any sense. So I think that. And there are some negative potential problems with the dual mobility, and one was interprosthetic dislocation, but there's others. The liner might not be properly seated if the exposure is not good, and there may be neck liner impingement, which can cause divots in the femoral neck. And there is in the dual and modular side, there's things that could be moving around, creating debris. So it's not without some potential negative benefit, but at the end of the day, it's mostly about cost.
Yeah. Yeah, and I agree with that. I mean, that was my um, discussion with my attending. I said, you're willing to pay for the difference. I think we'll go ahead with your decision making, but that didn't go over well. That didn't go. I don't know why, but you know, let's talk about a little bit about approaches. Direct anterior, posterior. Is there, there appears to be fewer dislocations in direct anterior. Um, and so, would you less likely use a dual mobility in a direct anterior approach versus if you're a posterior approach person? What do you guys think about that? Bill, you exclusively use direct anterior now, right?
Yeah, so I've been doing direct anterior for over 20 years now, and
Yeah.
even prior to that, it was direct lateral.
Yeah.
So I'd never really done posterior approach. So it's hard for me to comment, on posterior approach from personal experience, at least. Yeah, and I get your point. I mean, if the dislocation rate's, 0.5%, why are you using dual mobility? I think that for me, it's especially in these smaller patients, more about impingement that will potentially lead to an early failure, because with the bearing surface we have now, these parts are probably going to last more than 2 decades because the poly doesn't wear out. And so if you can reduce that potential problem, which is impingement, that you might, reduce some early failure. So, it's hard to argue against using DA because it's really very stable. No question about that.
Yeah. Michael,
Yeah, I mean, I've been in practice a lot less time, but I've been doing anterior hips most of my career, basically my whole career, because I trained on them as a fellow. And that practice has grown. I came out of fellowship, I was probably, 60, 70% anterior, direct anterior, and it was 30% posterior. I don't really do direct lateral, anterior lateral. It's probably now become more like 90 to 95% direct anterior, as I've gotten more comfortable handling more complicated cases, larger patients and whatnot. I do think there is something to the DA approach in terms of implant position as well as preservation of short external rotators, things like that. But the back of the hip is the posterior capsule is just more intact. So I don't know that I'm less likely to use a dual mobility on an anterior approach. Probably. I think that would be skewed by the fact that most of my revisions are posterior, and a lot of revisions are conversions from prior hip fracture surgery. I'm using a dual mobility on those patients. So I do more through a posterior approach, but anterior hips can dislocate too if the parts aren't in properly.
Yeah, I get that. You have to, I think, reemphasize component position, soft tissue tension is important regardless of your approach. I would have to say, though, that, a lot of the spine deformity and spine hip relationship literature has been published by posterior approach surgeons. And I think I've talked to some of them at work in some of these institutions, and they're pretty honest about the fact that they can get the dislocation rate down to the same level as DA, but they have to be more aware of that spine problem and be more willing to use dual mobility components in certain patients.
That's a great point. Ross, you have some comments on that, or should I just let the word spinal go by
I have
without
no
talking?
problem with that. I mean, to argue that the posterior approach doesn't expose patients to higher dislocation risk is folly. It does. So they have to be way more cognizant of what they're doing. You get a little dislocation break when you go anterior. You can't argue with that. Not an impingement break. You don't get an impingement break. You get a dislocation break.
Yeah.
So let's talk a little bit. Let's switch to what Michael was talking about a little bit, and Bill probably has experience. What happens when dual mobilities go wrong?
I'll say we talked a little bit about if they dislocate, a reduction of that can be challenging. It's a large ball. It can pierce through the soft tissues. I've seen it. One thing I will say, and I think Bill already mentioned this a little bit, is a polyethylene bearing is pretty forgiving. You line it up, you hit it in, the locking mechanism engages. I think that there's different types of dual mobility liners and how they engage, but by and large, I think they're less forgiving. So a couple examples: if your screws aren't down all the way, if you're using screws for supplemental fixation, you're going to have either trouble getting the liner down, or you're going to deform the liner. The polyethylene, if that's the case, probably is more forgiving in that scenario. If you have impingement of a titanium neck on a polyethylene liner, it's probably more forgiving. Eventually that liner may fracture or fragment, but metal, a cobalt chrome liner on a titanium neck, if you have implant prosthetic impingement, you may get metallosis. There's a surgeon in my area that I think has maybe some issues with exposure and visualization, and I'm not convinced that when he uses a lot of dual mobility, actually, I'm not convinced he seats the liner perfectly every time, and I think he's had some issues with that, including corrosion. So I think that it's not a totally benign thing. If you use it really properly, I think it worked great. But there are some technical aspects of it that are very important to follow.
Yeah, I emphasize if it dislocates, it's pretty much going to be an operative relocation of some sort. I mean, you occasionally can get away with that, but that's different than a dislocation from a standard bearing, right? And the other points that were just mentioned are absolutely appropriate too. So, but the dislocation, when it happens, is a surgical treatment.
Excellent. And we have some other questions. Marty Nichols.
Yeah, I was just curious about your thought process with dual mobility on ceramic versus metal. When and where to use them, and is cost an issue in that, I assume, as well too, if you're worried about the cost of the DM.
I'll take that first. I mean, we made a decision to go to all ceramic heads, and even in the regular hips, and again, it was more about a fear about adverse soft tissue related to corrosion, right? And not necessarily a real fear, because it's not a very common problem in the standard hip replacement, but We say, well, you don't have to use an older person. They might not live that long. But the problem with adverse soft tissue reaction, it occurs in the first 2 years. So I don't want to be doing revisions on people that are older who have hip fractures for something that could be prevented with a slightly more expensive femoral head.
Yeah, I mean, ceramic, I think, ceramics are the way to go for the inner ball. There are some obvious cases where you can't use ceramic, but if I do a bipolar for hip fracture, I'm using a metal head usually. That the outer ball's metal anyway. Might as well have another metal ball in there, I suppose. Um, Tom Faring at Ortho Carolina published a paper looking at cost effectiveness of ceramic heads, looking at the risk of adverse local tissue reaction from cobalt chrome. I think it was cost effective even up to the age of 85 or something like that for total hips. So I'm ceramic all the time unless there's some extenuating circumstance.
Another plan is to just negotiate the ceramic price lower. I'm sure
Sure.
the reps
That
love.
ain't gonna happen.
I know. But it seems like a reasonable idea. Nicholas Danello. Nick, you have a question about a troch nail. If you want to unmute yourself, Nick, I'll give you a few seconds. All right, I'll ask it then. When converting a troch nail to a total hip, are you always using a dual mobility?
I've moved in that direction. Actually, there's some good literature supporting that. I'll tell you, most of the troch nails I revise or convert to total hips. They're number one. The troch, the abductors have been violated, a little bit at least. So there may be some abductor deficiency, and the majority of those fractures have some form of either malunion of the trochanter or heterotopic ossification. And the impingement that they produce when going into flexion is pretty impressive. So I'm usually using a modular stem, like a Wagner style modular stem, adding some anteversion and doing a dual mobility on those patients because I think their risk of dislocation may be higher than anybody's for those two reasons that I just stated.
Yeah. Bill?
That was a good answer. I'll leave it at that.
Leave it at that. Awesome. Awesome. Yeah, we talk about the availability of the monoblock, and so I'd like you to describe the monoblock for us. What exactly is it, and what does it look like, and what would be this besides the special advantages of the small patient? Is it a replacement for every size eventually?
Yeah, I guess I can say what I want to say. Mike, you can adjust my answer whichever way you want. But so it's a hemispherical cup with an extra 2 millimeters extension, sort of cylindrical extension. Otherwise, it looks like a regular cup, a HA coated, plasma porous coated cup, and it's prepared with reamers the same way. The reamers have the same sort of shape. And as Mike explained, it's a very good press fit. The instrumentation is actually pretty awesome. And you can use it pretty much in all sizes. Again, it's one of those things I tend to be very selective for it because I have the modular dual mobility, which I tend to use in the bigger sizes, just because it's equally good there. If you're going to use this monoblock, you have to be very comfortable not using screws because you can't.
Yeah.
Right? So that limits some of the choices some of the time.
Yeah, and I was going to bring that up about the idea of these screws and burning implants and having to put a bigger one in
if someone was going to say try that, I would suggest they become comfortable using the standard hemispherical cup and not putting screws in first to make sure they're comfortable doing cup implantation without screws.
Yeah, I agree with all that. And I would add just, for anyone that's familiar with like Birmingham or any type of hip resurfacing, the acetabulum component looks a little bit like that. It's one piece. There's no screws. Inserting it is a little different because there's nothing to thread onto. You have to use it's sort of like a suction type device that, and the equipment is pretty nice for it. I think it really, you get your biggest bang for your buck on those smaller patients, and patients that you can not use screws on. Earlier today, actually, I was hoping to use one, but the patient had a little bit of a protrusio deformity, and she didn't really have much of a medial wall. And so I was a little worried if I press fit that, the monoblock dual mobility, I was worried that might lose fixation because there really wasn't a medial wall. So I ended up going back to a standard hemispherical cup before implanting that, so I could put screws in. And and the reason why I did it was because she was a really small patient. It was probably going to be a 46 or 48 cup. She's late 70s and has a horrible spine. So that's why I chose to do that. But I think in the larger sizes, what's interesting is because it's all proportional. If you get into the huge sizes, now the ball is so big that I actually don't know if it's the right thing to do, because you might have non-anatomic femoral heads, femoral heads that are in the 50s and even 60s or so. So I think in the bigger sizes, I haven't used them much, but it's the small sizes that I think really help.
Awesome. Russ, you had another question there.
Yeah, I'm trying to help move the discussion along different things. I was at
Sure.
the European Hip Society, and they this year, and they gave out a magazine. In it was a discussion of dual mobility cups and all the factors that go into jump distance. And what really hit me is how many factors beside head size matter in the design, and that there's a huge variability in the design of dual mobility cups, to the point where actual jump distances can be really different. So I think we need more discussion, more understanding of those factors that determine jump distance within dual mobility cups. And that's really, to me, an esoteric kind of question. I didn't know much about it. I don't know if any of the panel members have looked at this, but we tend to think dual mobility and they're all the same. They are not.
Yeah, so again, I may not have a complete understanding about it, but here's what I do know is that a lot of it depends on, in terms of the jump distance, depends on where the center of the head rotation is. So if it's deeper into the cup, you'll have a bigger jump distance. But some cups are made with a more where the center of the head is a little bit more out in the periphery. So that cup will have a lower jump distance, but a better range of motion before impingement. So I think you need to, so there's two things that are at play here: is range of motion before impingement and jump distance. So depending on what the reason you're using the cup. So for revisions, I think it's jump distance, right? You need, because they have soft tissue instability. In primaries, there's a little different rationale for using it. So again, look, I think it's important to understand the specifics of the cup that you're using and understand what the differences are. I agree.
Yeah. One of the things that hit me, and that when I read that article, was the inclination angle that you put the cup in actually has a big effect, with lower inclination, sort of a roof over it, being much better. And I don't remember the equation for that angle, but just knowing like 40 is good and 50 is not good for jump distances.
Yeah, and again, I could argue that that might be a good reason to start using three-dimensional planning and the CT scans, and to kind of plan component position, even if you're not using dual mobility, because there's lots of variations, and it's important to try to understand where the impingement might occur and adjust component position accordingly.
I think jump distance is probably far more complicated than simple equations. Like Bill just sort of alluded to. The way I always understood jump distance was really the half the diameter of the effective head, or the radius of the head, plus any additional buildup that the liner might have. So the larger the ball, and the obviously the bigger the jump distance, and there are other factors that go into that, I think. And everything's a trade-off. If you add buildup at the wall, if you add a few millimeters, you might add to the jump distance, but you're going to start adding to impingement. So there's trade-offs, and I'm not sure even though I agree, there are a lot of differences in the dual mobilities out there on the market, and there's probably 5 or 6 different companies out there that make them. I don't think we truly know like which variables really matter the most, although jump distance is the one we talk about.
Now, have you ever any, Michael, backing you up on this, have you had any problems related to this with the choices that you've used with MDM? Or is this just maybe a theoretical discussion?
Personally, I really don't think I've had too many problems, and I don't think it's safe for anyone to say they've had no problems because we don't know where our patients always go. But I think I'm selective on when I use them. I think I'm careful and meticulous, and I think a very dedicated arthroplasty surgeon should be. But so I can't say off that I've had too many issues. I have seen other surgeons have issues, and it probably has to do with, like I mentioned earlier, it has to do with implant position. It has to do with, paying close attention to how you're putting in the liner. So I think that matters. I have seen the issues. I don't know that I've had them happen to my patients.
Yep.
Yeah,
Bill,
the American Joint Registry suggests that there's a higher revision rate with dual mobility bearings, which is kind of weird. But I think the problem is it's a patient selection bias because you're putting it in patients at higher risk of having problems. So I don't know that you can use that data to condemn the dual mobility. But yeah, you do enough of these surgeries, you're going to have problems at some point. It's like nothing is ever zero. I had an intraprosthetic dislocation this year. It just that was the first one in 20 years I've ever seen. So, it happens, right? We just looked at our 10-year data, and it's going to be published in another journal this next year. And, they're really, the patients do well. And we had no revisions for adverse soft tissue reactions. And yeah, there was one or two patients had slight elevations of cobalt, but no symptoms. And patients were doing well at 10 years. So some of the theoretical complications are not real. They're there, but they're not really a problem. But yeah, to say that there's no complications now, there's complications.
yeah, that's good. John, you want to talk about your post?
Yeah, I was just going to say that, and I'm not familiar with all the different, monoblocks and all the different shells, obviously, but some of the shells out there actually do have some raised or sort of peripheral, raised. I guess a lip would be the best description, but the idea behind it is that you can orient that. For example, if you're maybe more concerned with a posterior dislocator, that just in those few millimeters potentially can make a difference. And I think that's why it's built into, for example, the Link shell has that option. And again, I'm not sure about other ones. There may be other ones out there with that.
Yeah.
Can I just ask you a question? You mean when you say it's a dual mobility, it's a modular dual mobility, and it has a face changing to it or a build up on one?
No, and it's not a face changer. It actually is a monoblock that has just a raised area along the margin that again, it provides for orientation. If you have maybe a concern about say a posterior or anterior dislocator, you can actually turn that somewhat. It just gives more surface area, for that liner.
Sure.
Yeah, very interesting.
Again, I always I don't think, as you said, nobody knows what the right answer is. But the concern I have with raised lips is the impingement, and that can cause a dislocation in the opposite direction. So that's always, So yeah, with any change, there comes a potential cost.
Absolutely.
Yep. And has anyone talked about or have experience with cemented dual mobility, or just everyone's just on cemented and we just bury that topic?
We're Americans, right? Yeah, so we're going to go somewhere else.
The role for cemented dual mobility is there in two-stage exchange for infection.
Oh, okay.
And so you can put antibiotics into cement, you can get a highly stable bearing. And so that is probably the most important role for cemented dual mobility. And now I think that's a real role. So I think there is a role.
Are you using those for your spacer, or you're not using those for the replant, you're using for the spacer?
The spacer, yeah, it's a spacer. I guess you could use it for the replant, but usually you go cementless, right? In the replant. So this would be for the spacer, which can turn into a longer process. You can be there for quite a while sometimes, if you get my point. Yeah, sometimes they don't come back for a while, but yeah.
Yeah, shameless plug also for I did a LinkedIn post where I did a tri-flange based off that PEC material, and it was basically custom made. It fit beautifully, but I used a dual mobility liner for that patient, and it was essentially it was like a biggest 1.5 you're gonna see in terms of a spacer, but the idea of doing anything short of a dual mobility, I wasn't going to do that, and that worked out great so far.
Yeah, I think I've done several, not a ton, but a few, and I think the best indication is in the like a cage type setting. You have a cage, whether it's a custom cage, tri-flange, and it doesn't have its own proprietary liner or locking mechanism where you could cement it in. It really is a nice option. You don't get as large of a bearing because you lose some size with the cement mantle, but it's still better than cementing in a polyethylene liner. It gives you better options, I think, and it gives you that dual mobility concept. Or a revision scenario where maybe you don't want to revise the cup, but the liner, it's an old cup and the liner options are limited, or the cup position is a little compromised. You could cement that dual mobility liner into that old cup, and you could change the position a little bit, or get a large bearing. So I think it works pretty well.
Great. So we've run a lot of topics tonight, and it's towards the end of the hour. I just want each of the panelists to. Oh, no, we got another question. Okay, Marco Tolokin. You want to unmute yourself, or we'll ask you a question for you. All right. Do you routinely perform sagittal pinopelvic assessments?
Just so you know, Marco Tolokin was a fellow with Rothman Institute at one time. So,
Oh, all right. He's an alum. He's an alum.
Marco. Yeah.
Hey, Marco. Good. And the fellows back in the early 90s were better, Marco. I just want to point that out.
So I don't routinely do spine evaluation. I think it's probably my legacy of doing supine direct anterior and supine direct lateral hips. I've just never had the issue with instability, regardless of the spine situation. I'm not saying that's the right answer, but that's what I do.
I do not routinely, but that being said, I think there's value in it. I think a lot of it depends on where you practice and what your capabilities are. I primarily practice in either a private office or a hospital that doesn't really have the capabilities to do that on a regular basis. And I also don't know that I have the bandwidth to go through and run all those lines. But that being said, I do look at their standing pelvis, and if I really have some concerns, I might get lumbar spine films. But it's not as scientific. It's a little bit more artsy, trying to figure out if they're if they're rigid, if they're stuck sitting or stuck standing, as we call it. But it's very unscientific, and it's not like the way it's presented at these big meetings.
Interesting. Okay. We'll keep it at that, and we'll sum up now. What is always the fastest time in orthopedics, the Joey open mic hour. We'll start with you, Bill, this time. I want you to sum up about MDM and mobile bearing and some take-home messages, because I think this eventually lends itself to an "In My Experience" article, which because there's so many pearls tonight about dual mobility. So maybe you could sum up for us some final thoughts, some takeaway messages for people who will be watching this video.
Yeah, I'll try to give it, try to keep it simple. I mean, the current role for me for dual mobility, right, is in number one on the list would be revision hip replacement. I think in other cases, in primary hip replacement for spine fusions, if selected paces, neuromuscular disease, hip fractures, patients with cognitive disorders. And actually, for me, a very common reason now is intraoperatively when I'm seeing impingement in small bone patients. So I'm more inclined to use dual mobility, the monoblock dual mobility in the small bone patient. I'm talking about 48 millimeters and below, where I cannot get in a 36 head.
Great. Michael? Baratz?
Yeah, I mean, You got it. Yeah, I would say first of all, everything Bill said, I agree with. So I'm not going to repeat that. It's absolutely how I feel about it, about the use of dual mobility. I would just say my summary is, it's an excellent tool. It's a really nice option. I think it should be used selectively. When I'm doing revisions or big conversions, I use it more. There are costs, both financial, and there are consequences when they're used too often or not used properly. So use it properly and it will work well, and don't overuse it, because I don't think it should be used for every patient.
Right. So this is good. Unless someone else has any comments, I want to thank both of our panelists tonight. This is important topic, one that is, while some have used it for many years, some are newly using it and discovering its uses. I want to thank John Minter and Russ Bodner as well for chipping in, and I'll say good night to everybody.